Well, thank you everybody for joining us. I'm Lisa Goldthwaite, as Dr. Shah said, and we'll be presenting a two-part discussion of family planning perspectives on maternal mortality. She and I are both faculty in the Department of Obstetrics and Gynecology. For my part, I am a generalist OBGYN. I also am a family planning specialist, so I specialize in abortion care and complex contraception. And I also am lucky enough to have started a career in some global health work, a lot of which I'll mention kind of peppered throughout this talk. But just to warn you, my half of the talk might be a little on the doom and gloom side. Dr. Shah hopefully will bring the feeling of positive energy back up. We have no relevant disclosures, and overall, over both of our talks, our objectives are to help you recognize global trends and disparities in maternal mortality, unsafe abortion, and unmet need for family planning. In addition to defining these, we really want to show how they all blend together and how they're really interconnected. We also want to be able to describe interventions to reduce maternal mortality and the role of harm reduction in achieving safer abortion. All right, so we'll get started with my half, a global health overview. Every day, approximately 830 women die from preventable causes related to pregnancy and childbirth. 99% of maternal deaths occur in developing countries. Maternal mortality is higher in women living in rural areas and among poorer communities. And young and adolescent women face higher risk of complications and death as a result of pregnancy than other women. It's facts like these that draw me to do the work that I do in my small realm of trying to make a difference in the world. And in one of my earliest global health trips that I've gotten to take in my career, this is a picture from a hospital I worked at in Pakistan. And just to show you an example of their labor board, on my labor board, we have a number of women having deliveries here at Stanford. In my entire career, I've seen one eclamptic seizure. And this one random day that I walked onto a labor floor in Pakistan, they had over 70 women who had delivered in the last 12 hours, and 4 of them had undergone eclamptic seizures or had a ruptured uterus and were in life-threatening critical condition. And I felt so humbled to be in a space where doctors were taking care of women at this extreme edge of needing care. And what it really makes me feel like as a doctor is how much we are missing in terms of preventing these outcomes for women around the world. So how do we talk about maternal death? What are some major measures we use? Maternal mortality ratio, or the MMR, is the number of maternal deaths per 100,000 live births over any specific time period, usually measured over a year. And I think one of the measures that I think hits home more than any for me is a woman's lifetime risk of maternal death, which is the probability that a 15-year-old woman will die eventually from a natural cause or from a maternal cause if she experiences throughout her lifetime the risks of maternal health and the overall levels of fertility and mortality that are observed for a given population. So for example, as an American woman who basically will live most of my entire life in the United States, I will have the lifetime risk of maternal death of the United States. If a woman from Nigeria moves to the US when she's 1 year old, she will basically have that lifetime risk as an American. So it has to do with kind of the milieu in which you are living. In terms of maternal mortality ratio, this is the first of many maps I'm going to show you of the world. And the theme with all of them will be that globally, the global south really has these darker colors, in this case showing higher maternal mortality ratios around the world, pretty significantly across most of the African continent, but peppered throughout the world. You see numbers that are up there in the range of 1,000 maternal deaths per 100,000 live births. This is an incredibly high ratio. So what are those numbers broken down to regions? In developed regions, the maternal mortality ratio is in the ballpark of 12 on average across all countries, meaning 12 deaths per 100,000 live births. And the lifetime risk of death is in the ballpark of 1 in 5,000 in developed countries. Again, this ranges enormously if we break that down by individual countries. In developing countries, this is particularly notably different, with a much higher maternal mortality ratio and a much lower risk of maternal death, a lifetime risk of maternal death. If we focus even a little more in on sub-Saharan Africa, where we see some of our most dire situations, the maternal mortality ratio is almost double what it is already in developing regions. I had the experience, kind of surreal experience of doing a project working to support abortion training program in Nigeria this fall, followed the week later by a vacation alone in Norway. It's a very interesting 2 weeks to experience. And so just to highlight the incredible discrepancy between these two countries, a woman in Nigeria has a lifetime risk of maternal death of 1 in 22. 1 in 22 women walking around will die of something related to maternity or childbirth, with a maternal mortality ratio of 814. In Norway, lifetime risk of maternal death is almost 1 in 12,000 or 11,000. Incredibly different. And that's literally because they live in different places with different priorities, different access, different resources. It's not because we don't have the tools to help all of these women. So what are the causes of maternal death? These 4 are the ones that come to almost everyone's mind almost all the time when they think about maternal mortality. The one that a lot of people forget about is unsafe abortion, and that's the main direction I want to take this talk from here on out. These 5 major categories account for nearly 75% of all maternal mortality in the world. So what is an unsafe abortion specifically? It is a procedure for terminating a pregnancy performed by persons lacking the necessary skills or in an environment not in conformity with minimal medical standards, or both. One of my favorite ways to describe this to my trainees or medical students is that as a highly skilled family planning trained physician who does abortion care every single week of her life, you could put me down in the middle of a campground in Eastern Oregon with no running water and no tools around me to use and no medications, and ask me to do an abortion for a woman. And no matter what happens, that's an unsafe scenario, right? Or you can put my sister, who's a minister, in my operating room here at Stanford with all the resources anyone could possibly imagine, and she will never be able to do a safe abortion for someone. Those are 2 versions of an unsafe abortion, right? If you put those 2 things together, so someone without skills and then without any resources in the same scenario, that will be the least safe type of abortion you can imagine. So out of the 56 million abortions that we estimate happen every year around the entire world, approximately 25 million of these are unsafe. I'll let you sit with that number for a minute, because I think it is really powerful to imagine that nearly half of abortions in this world are happening in an unsafe way. And the risks associated with that are extreme. Now, there are lots of ways since the dawn of humanity people have been trying to not be pregnant when they get pregnant. And you can imagine there's a huge spectrum of risk in terms of all of that, right? Currently, we have medications like misoprostol that Dr. Shah is going to talk a lot more about that a woman might be able to get her hands on and actually have a relatively safe, unsafe abortion. She may not know how to take it. She may not know the timing or the dose. She may not be in a place where she can safely experience that situation. She may be at risk of intimate partner violence if her partner finds out that she's doing this, right? There's so many factors to that. But in and of itself, using a medication like misoprostol might entail a fairly safe, unsafe abortion. On the other end of the spectrum, there are people who try to put any number of things into their body, their uterus, trauma to their body, being kicked downstairs, using coat hangers. The list goes on, and there's an incredible history that we can read about this. And some of those lead to death. So it's really hard to estimate the number of unsafe abortions happening around the world and their contribution to maternal mortality statistics, but somewhere in the ballpark of 8 to 18% of all maternal deaths are actually related to unsafe abortion. And unsafe abortion-related maternal deaths are quite different country to country, region to region as well. Abortion in and of itself is an incredibly safe procedure. It's exceedingly rare in many countries, including our own, to have a death related to abortion. It certainly still happens. We can't drive that number to 0 because complications happen for women. But that is incredibly rare when it's done in a safe environment. It's really different across the world, though. If laws are restrictive, if people don't have access to care, if the types of abortions they're having are truly unsafe, no matter how hard people are working to keep them safer, those risks of death will go up. And you can see this dramatically across the world. This is a chart showing you between 1990 and 2008, so a little bit of progress. This is already a decade-old data. The global numbers are pretty stark, but in developed regions, in Europe, in the United States, for example, our numbers are pretty good and still working on going down. Of the 25 million women who have unsafe abortions annually, about 98% of them are in the developing world. Almost 7 million are treated for complications, but that means that an enormous number go untreated. 40% or so will never receive any kind of treatment for whatever the complication was, whether it was minor or major. And about 7 million of those women will suffer long-term disability. And this could be something like an infection they develop related to the procedure that then goes on to cause long-term infertility or sterility. They may have a fistula develop from an unsafe surgical procedure. There's any number of long-term sequelae that can develop. Luckily, many women's bodies are resilient, and many of these women who have complications will not go on to die, and those who don't die may go on to lead very healthy, normal lives and not ever tell anyone this ever happened to them. So it's really hard to capture some of this data. But about 44,000 of these women will die, and sadly, 91% of those are really concentrated around the world. This is a picture from a clinic that I visited in the Democratic Republic of the Congo. It says naissance désirable, which is desired births, and this is always one of kind of the mantras of any clinic or world that I'm working in. So what about restrictions? Lots of countries are trying to restrict women's access to safe abortion, and what we do know is that that does not help in terms of reducing the numbers of abortion. If anything, what we see from charts like this is that there are more abortions happening in countries that have more restrictive laws, and we think a lot of that is tied also to more challenging access to family planning or contraception in certain scenarios. But in countries where abortion is prohibited altogether or permitted only to save the life of a woman, around 37 per 1,000 women of reproductive age will have an abortion. Countries where abortion is available on request, it's pretty similar, and like I said, if anything, lower at about 34 per 1,000 women. And as we discuss the kind of safe, less safe, least safe scenario of abortion care, as we add on more restrictions, we see more and more proportions of unsafe and least safe types of abortion. And no matter what, those abortions still happen, they just become less safe. And so looking globally again, another big world map, this one from the Center for Reproductive Rights, as of 2019, in the most summative way we can, even though this is so nuanced and really hard to represent on a large map. In this graph, you see the countries in green have, in general, access to abortion without too many restrictions. And then all the way down to the red, showing basically either completely prohibited abortion restrictions or only to save the life of a woman. Again, we see the global south is more affected by these laws. So what happens when we make laws that allow for women to have safe abortions? The United States is an excellent example where we have a fairly good demographic memory of what happened throughout the 1960s, 70s, 80s. And as you see here, we see this giant drop in abortion-related mortality in the United States. So around the 1970s, even though that precedes when abortion was legalized federally in this country, we already had up to 15 states that had partially or completely legalized abortion and had made access much more accessible. And along with that, kind of revolutions in medical care to help allow for safer abortions. And we see the case fatality rate go down from about 4 deaths per 100,000 abortions to less than 1 per 100,000 abortions. You can see that go down even more after Roe v. Wade Supreme Court decision in 1973. And then that has really gone down as low as we can possibly drive it. We hope to keep always driving it lower. This same type of graph has been replicated in other countries, such as South Africa, where they legalized abortion, and we saw enormous changes in their maternal mortality. And the legalization of abortion ranks with the discovery of antibiotics in terms of overall decrease in mortality. These are incredibly powerful public health outcomes. So the last piece of the puzzle that I want to introduce before I let Dr. Shah take over is the concept of unmet need for family planning, because I think that all of these concepts really go hand in hand, and a lot of the problems and solutions really run together. This is a picture of some doctors in Madagascar, and the doctor in the middle is from Burundi. They're doctors working to learn how to use various types of IUDs, trying to increase access around the world in a project I got to do in Madagascar. Unmet need for family planning is another big definition that we need to learn. So it's the percentage of women of reproductive age, either married or in a union, who have an unmet need for family planning. And unmet need basically means that they have stated or are clearly shown to not be interested in having a child right now, delaying or never having a child, but they're not able to currently use or not accessing contraception in any way. So this isn't just the number of women out there who aren't using birth control. This is the number of women who would like to be using birth control who can't have access to it. And it's a very interesting number, right? By only following people globally in these large demographic surveys who are married or in a union. This is obviously grossly underestimating the number of women who aren't using contraception who would like to be. However, we just have our hands tied in a lot of countries with demographic health surveys, being able to ask questions that are reasonable for that environment. And in many parts of the world, it is unacceptable to even imagine that a woman might, outside of a union, have a need for contraception. So as of right now, this is one of the best indicators we have. We know that it's really just a marker for a lot more, but it does at least allow us to track something over time. And here's probably my last large graph I'll show you of the entire world laying out. But here you see the unmet need for family planning. So again, among married or women or in unions who do not currently use birth control but would like to be using birth control of some kind. As of 2019, the red countries are upwards of close to 30% of women have an unmet need for family planning, down to the lower color in the yellow, which is closer to kind of under 14%. So again, really wide differences across the world. It's a problem that every country faces and is something that we're really striving to reduce. So I will leave you with one really important thought, as said by the past president of the International Federation of Gynecology and Obstetrics. Women are not dying because of diseases they cannot treat. They are dying because societies have yet to decide their lives are worth saving.
Can you hear me okay? So as promised, we're leaving you on a low note. And another disclosure is I am an optimist, and that's a lot of what drives me. So I really think about this as something, there are things we can do, right? We have the tools, we just need to have the reason and the drive. So for me, that means, as we heard in our first talk, right, the impact that research can have on helping this, the impact of medical care. And for me, a big drive is the training of medical students and residents and how we can improve this. And so I'm hoping to really paint that picture of how we can really move forward. And I'm not alone, right? So the UN got together in 2000 and established the 8 International Development Goals, really focused on poverty, health, environment, education, gender equity, and global partnership. And all 189 UN members at the time and 23 other organizations got together to commit to helping to achieve these goals. Specific to women's and reproductive health, they committed to reducing maternal mortality ratio, as we talked about, by 75% and increasing contraceptive prevalence and decreasing the unmet need for contraception. And so that's what we're going to talk about here. So thinking about those top causes of maternal mortality that Lisa went over, there's interventions for all of these that have been shown to be effective to decrease mortality, and these are a lot of the focuses for the development goals, the UN initiatives, and some of the WHO initiatives. But today we're going to really focus on these family planning ones. So really about first step to decreasing mortality, both directly, but then also through contraception, by allowing people to decide whether and when they want to be pregnant and how many children they want to have. So in April of 2012, at the London Summit for Family Planning, FP 2020 was founded. This was an unprecedented global commitment and allocation of resources, which is important, by governments, civil society, multilateral organizations, research and development people, private sectors, donors. And really their goal was to enable 120 million extra girls and women to use contraception by 2020. And this really grew out of the Millennium Development Goals to say, what are the countries that really are disparate from other countries, and how can we help lift them up to help them achieve the goals of the Millennium Development Goals? And so they really focused these efforts in 69 of those countries that really needed the most help with their maternal mortality, and specifically unsafe abortion. So of the maps that Lisa showed you, you see that a lot of the things overlapped, right? The areas of the world with more unsafe abortion deaths, higher maternal mortality, more restrictive abortion laws, those are the same regions of the world, and those were many of the countries that was focused on for FP 2020. and really based on the principle that all women, no matter where they live, should have access to safe abortion and modern contraceptive methods. So some of their key principles were to increase the demand and support for family planning, to improve supply chains, systems, and service delivery models, and to procure the additional commodities that countries needed to reach their goals. And this is where having donors behind you really helps, but it was also about working with ministries of health and countries to ensure that they were getting supply chains to work on this. And part of this comes from the rights-based framework of the FP 2020, which is to ensure that women have a choice of their method. So that it's not that there's a method available, that people have the choice and the autonomy to decide what is right for them, and that means having more methods available. So through efforts to ensure supply chains, to ensure trained providers, to ensure education around methods, those are all part of these first three principles. Additionally, they looked at fostering innovation around some of the family planning challenges, so really empowering people to look at what are the challenges and how can we fix them. And then promoting accountability. And this is really through improved monitoring and evaluation. So for researchers in the room, like how do you monitor this, right? So what are the indicators that you're going to use to show that this is working and that you're achieving your goals? So the MMR is one, right, with the maternal mortality ratio is one that you can look at, but there's often much more to it than that. And how do you capture some of the rights-based framework about coercion and autonomy with an indicator? And so how can you ensure that people are implementing these programs in a way that's actually positive? And so that's been a lot of the focus for the evaluation and accountability for this, especially when it comes to countries accepting huge monies to incorporate these. We want to make sure that they're accountable to the right things. And so some of the efforts have been around the supplies, but also about the trained providers. And so as we think about the most effective contraceptive options are often ones that require a provider for initiation. So things like an intrauterine device or IUD or a subdermal implant require that a provider initiate that. So how can we create systems to ensure that people have access to those? Requires both ensuring that the method is in the country, that the person can access it at their touch point to the care, and that there's a care provider that can both initiate it and remove it as the person wants, because if they have autonomy, reproductive autonomy, that would mean both initiating and uninitiating contraception. So here's just an example. This was a Madagascar program where the hormonal IUD was a new method introduced into the country, and this training program that Dr. Goldthwaite ran was around ensuring providers knew how to initiate and use this method and how to provide education to people about this method. In addition, some of the other efforts around contraception often link to the other efforts happening. So one of the specific call-outs and the indicators used to look at the original Millennium Development Goals was around increasing the proportion of births that were attended by a skilled birth attendant. So we know that alone, just having someone that can recognize when something's going wrong and intervene or get the help that they need decreases maternal mortality. And so by encouraging that, they showed that was a success, that we were able to encourage people to have skilled birth attendants. And oftentimes that meant that people traveled for several days to get to a place that they could have an attended birth and stayed there until they had their birth and then went home. And that meant they probably weren't going to have access to contraception outside of that touch point because they didn't live at a place where they had that kind of resource. And so tying to that, the opportunity to provide people in the postpartum period, the immediate postpartum period, with contraceptive services has been a really great initiative and a way to increase access for people that want contraception. Because we know that they just had a baby, they often want to space their pregnancies, and the majority of people don't want to be pregnant again within that first year. And so really kind of linking those services has been another great success. And we've done many of those training programs as well on how to initiate that in the immediate postpartum period, which is a little bit different than outside of that period. So since its inception in 2012, an additional 46 million, so that's this top orange line, people, women and girls were using modern methods of contraception in these 69 countries. Now this baseline here, you can see it's over 200 million people. So even to maintain 200 million contraceptive users in these settings, it requires a large programmatic effort. And so to continue to increase that is a great achievement. And then in 2017, there was another summit that got together. There was some concern about a change in US aid related to FP 2020, and that motivated a lot of donors, and there was a huge uptick in the amount of money that went into FP 2020, as well as the number of people committed to it. So they had an additional 120 new commitment makers that jumped on board in 2017, which makes this jump we still have to 120 million feel a little less big. So hopefully that will get there. So unsafe abortion. What is it? So as we've well defined that, and in places like Nigeria, we'd love to get to safe abortion, right? But there's a long way to go between those things, right? There's training, there's laws, and some of those can be unsurmountable. But what we've seen over time, so traditionally abortion and post-abortion care was done with an instrument like this. So this is a rigid metal instrument. It's called a sharp curette, and it is not as effective at abortion or post-abortion care, and it was associated with more complications. Over time, we've replaced this, and now we have newer methods to evacuate a uterus or medications that can help to cause an abortion or help with post-abortion care, which are complications related to either an unsafe abortion or a miscarriage or a self-induced abortion. So what are some of these methods? So misoprostol was kind of a big win in the family planning realm and in women's health. It's a synthetic prostaglandin, and it's orally active, and it actually was developed about 30 years ago, approved in the US to prevent gastric ulcers. So nothing to do with OBGYN at the time. But it was found to have the side effect of causing uterine contractions and cervical dilation, and this side effect quickly made it very commonly used in obstetric and gynecologic indications. So it was good for labor induction, it was good for inducing abortion, miscarriage, preventing bleeding associated with miscarriage, and it quickly became widely used in OBGYN. And so in addition, it's inexpensive. It can be stored at room temperature, and it's just taken orally, vaginally, or buccally, or sublingually. So it's something people could administer themselves. It doesn't require an IV, doesn't require special storage, making it a very, very attractive medication. And because of all this, by 2005, so within 20 years of its discovery, the WHO added it to the essential medicines list. And so here you see by 2008, just within a few years of approval, more and more countries were starting to adopt it. So again, thinking about those other maps, I want you to keep orienting back to that, because you can see here where it wasn't approved in 2008 is the same countries that had a high unsafe abortion. And that was part of the problem, right? This talking about bringing in a medication that could be used for abortion wasn't necessarily very popular in countries where it was illegal. But the impact of this intervention in all the other countries and the building evidence, right, researchers, the building evidence that was coming about on the impact that this could have really started to move the dial and increase the number of countries that had it. So by 2017, you see more and more countries with this drug available in the country. And that could be that it's just approved for postpartum hemorrhage, but now it's in the country and people can obtain it and use it for other indications, even if it's illegally. And that itself has impact on decreasing maternal mortality. In addition, for surgical procedures, in order to make them safer, this was developed. This is a simple manual vacuum aspirator that was developed in the 1970s and has really replaced the sharp curette for safe abortion and post-abortion care and miscarriage management in most developed countries, and really making headway into developing countries as far as being incorporated. There's a lot of NGOs and World Health Organization and others that are working with countries with high unsafe abortion rates to improve the use of this in order to decrease the complications associated with sharp curette or other methods. This doesn't require an operating room. It can be done in just a clean clinic. It doesn't require a lot of resources or equipment, and so it makes it a really portable, easy to use, easy to train piece of equipment. So again, organizations like IPASS, Marie Stopes, PSI, and many others, which are NGOs, have worked with the Ministries of Health in different countries to train in those countries their providers on how to use the aspirator. This is a picture of here at Stanford training medical students and residents on how to use the aspirator. And we use these low-tech models. This is a papaya that's serving as the uterus. And we use these models in order to train on how to use this. And it can be used to treat bleeding associated with a miscarriage, to do an abortion, and, or to treat someone with complications after an abortion. And even in countries where abortion is illegal, we do these trainings in order to improve post-abortion care. So like in Bolivia here, the focus really was about how to use this technique for post-abortion care. So someone coming in with an incomplete abortion, whether that was because they self-induced with misoprostol and it was incomplete, or because they were having a spontaneous abortion, this is a technique that can really decrease mortality associated with bleeding around that, for example. So this can be a long way to go and a lot of hurdles in many places. And so it's not always possible to easily go from unsafe to safe, despite the technology being available. But we really can think about what are harm reduction strategies. So how can we make it safer? Even if we can't make it safe and available to everyone, how can we make what's happening safer for people? And so even where abortion is legal, this can be just to, again, incorporate the different techniques and technologies that we have in order to improve maternal mortality. And because of this, even in countries where it's not going to, the legality of it's not going to change, or we can't move the dial that much, we can improve post-abortion care and decrease mortality. And then this often, with other research looking at decriminalizing abortion or decreasing barriers, can also improve maternal mortality. So like in Bolivia, abortion's pretty much illegal. And it used to have 30,000 people every year admitted with complications from unsafe abortion. And then misoprostol came into the country and they saw a significant decrease in the people that they were seeing coming to the hospital because more people were getting misoprostol, albeit illegally, to manage their abortion. They were not instrumenting or having someone try to perform an unsafe abortion. And so they saw much fewer infections, bleeding, or even other more serious surgical complications. And so this really was great for them to see. And in that time, they've also seen that this can make an impact. And through organizations working with the Ministry of Health, they've looked at other ways to improve it. So it was only acceptable for rape, for example, but you had to go to a judge. And that was a huge barrier, could cause a long delay in order to get approval. And just by saying you don't have to go to a judge anymore, you just have to go to the police. That really improved the flow. People could access abortion earlier after rape, and it really decreased the barriers for them getting the care they needed. And then really recently, this was a big deal for South America, they decriminalized abortion under 8 weeks for any reason, for specifically students and adolescents or girls. And this was really specifically said by the Minister of Health, that this was about decreasing unsafe abortion and improving maternal mortality. So although Bolivia doesn't have safe abortion for all, they're making abortion safer by doing some of these harm reduction strategies. So how do we do? So in the 2015, that was kind of the target, so that's been a few years now, but the UN got together and said, how are we doing? How are we doing on these programs? So they didn't get the 3/4 reduction that they were aiming for by 2015, but they did get a good decrease, about 45%. And some countries had a greater decrease, and so some had even as high as 60% decrease through some of these efforts. And more people that wanted contraception were getting the contraception that they wanted, and so this was great. And they could control when and if they wanted to be pregnant. So you can see most of the reduction occurred between 2000 and 2015, and 2000 again was when they set these goals, so that was really did meet the dial. However, there's still a very large disparity in maternal mortality amongst the less developed and compared to the global average. And so here you see this huge difference, but you also see that the trend was towards decreasing maternal mortality in both parts of the world. But despite this average, you can see this breakdown. So each of these dots represents one of the 183 countries that was included in this data. You can see it spans all the way up and down. The US ranks in at 46 out of 183 at 14, meaning that all those other 45 countries had much lower maternal mortality ratios, as low as 3 deaths per every 100,000 births. We were at 14 per every 100,000 births, but when you compare that to Sierra Leone at 13,000 per 100,000 births, that's about 1 death for every 70 births. So still a huge difference across the world on how people do. So given all of this, in 2015, the UN got back together and started working on the post-2015 development. And you saw this slide earlier this morning, but the result of that was really looking at sustainable development goals. And as you heard our first speaker mention, like some of the things that we wanted to be specifically called out when you talk about global health became called out, right, as separate items as opposed to just a sub-indicator on some of the other categories. And so by expanding the categories, they really gave things the attention that they deserved. And so by 2030, specifically looking for global maternal health and reproductive health, you can see their goal is to continue to decrease maternal mortality, with no country being more than twice the global average. So this speaks to that decreasing that disparity and that breadth to really get everywhere doing better. And additionally, increasing universal access to family planning, including education and care provision, and integrating family planning into all the health strategies. So not siloing HIV and family planning, but integrating them. Not siloing postpartum care and family planning, but integrating them. And so that's another specific metric that they're looking at. And in addition, it was great to see that there was this focus on autonomy for people to decide when and if they wanted to be pregnant, to decide what they wanted to use for contraception, and to have access to it without coercion from anyone. And then also looking at decreasing gender equity specifically. And they really called out the informed choice aspect of this. And then they really blew it out of the water when they said they want to increase the laws protecting reproductive health. So this is kind of unprecedented. And we're seeing a trend within the US of like more and more laws that specifically protect reproductive health as opposed to just decreasing laws that are negative, but actually going so far as to say we're going to make legally protecting these services. So thinking back, so in 1990, for every 100 births in a developing country, 1 woman would die from pregnancy-related causes. That's what that 900 means. But by 2015, this was reduced by half. This is where we want to go. This is what the Sustainable Development Goals have said. So with an average of 70, no country twice above average. 140 is a big difference. This is a really aspirational goal. So 140 per 100,000 is closer to 1 in 1,000. So we're talking about a 1 in 100 in 1990 to 1 in 1,000 in 2030. That's a great goal. But this is still a big discrepancy. So even if everyone gets to 140, you're still talking about some people having a risk of 1 in 1,000 and some people having a risk in 1 in 30,000. So a big, big difference. And the majority of those in the world that have the highest chances of dying as a result of pregnancy or childbirth live in the poorest countries in the world and are without access to effective contraception and safe abortion. So access to safe and voluntary family planning is a human right, and it's essential to gender equity, empowerment, and overall health.